Academic Feast as a webinar on how to optimize the embryo transfer. It is the first activity of SIG chapter 2024-26 in collaboration with SIG Group Embryology chapter. So along with me, Dr. Sarabpreet and Dr. Ghosh and Dr. Pooja is there with me. And I just started this seminar starting from embryo transfer, how we will increase the implantation rate. So start from embryo transfer and how we increase the implantation rate, and ultimately what are the key take-home messages after this webinar. We will get some clue points to increase the success rate. And now I request Dr. Sweta ma'am to tell a few words about this.
Yeah, good evening, everyone. And it's a very good initiative that IFS, our Chhattisgarh chapter with SIG Embryology with Dr. Sarabpreet and Dr. Anuradha have joined together to have this very good meeting. So just for a few things I wanted to tell, being Secretary of Indian Fertility Society, that we are a very big society with over 4,000 members. And I'm very happy that I hope that all the chapters are getting their new members enrolled in the WhatsApp group, because I'm making sure that every day, every time a new member is enrolled, and I put it in the particular group, so the chapter secretary then takes over. Very important, I wanted to inform that we have very important 5 programs from the Central Secretariat which are going on. So I want that all the young Turks which are, are doctors who are doing fellowships, postgraduates, and younger consultants who are less than 45 years, to be a part of Young Turk group. You can be in touch with Farah and she'll make you join and present some journal clubs. Also, we are planning to get guidelines which are prevailing. Number 2, we have our artificial intelligence program, which is going on in a very robust manner. Then we have a Kahoot quiz, which is going on open for all, which we are clubbing it with our journal club once a month, and journal club is twice a month. Then we have, of course, we've recently started a self-empowerment program, which is more got to do with yoga, meditation, and making yourself better. We will be running our, patient awareness program, which is called Patient Empowerment Program, in a very big way. And we'll be launching it on World IVF Day. So we have, and then we have nurses program. So I want all of you to enroll your ART and nurses who are in, reproductive medicine or any kind of fertility, so that, they can also get a certification at the end of, these 5 programs. They need to be member of a registered medical council, the local, nursing medical council. And last is our counselors. This is also a counselor empowerment program. So make them join in the counselor empowerment program. It's a very informative program. And at the end of, say, 5 modules, we will come up with a checklist in Fertivision so everyone can keep it in their centers. The last 2 information is that we are doing our Fertivision in Ahmedabad. So please go on the website in December 6th, 7th, 8th. So please be a part of our Congress and participate, present. The abstracts submission has opened, as well as the early bird registration. And becoming a member of IFS is a very easy process now. It takes roughly about 5 to 6 minutes. So thank you for patiently hearing me. And I wish you all the best for today's CME and webinar.
Thank you, ma'am. Thank you. Thank you. I think Dr. Pankaj sir has not joined, so we can move ahead, ma'am, for the first session.
Yes. And if Dr. Sarabpreet wants to say something.
Yeah. Okay.
Yeah. So this program has been conceived to improve the clinical as well as the embryology practices. So the aim of the program is Dr. Anupama is going to speak on OPU, and then we're going to discuss about the implantation rates. So implantation rates was picked up because it was something, which requires clinical expertise, as well as a lot of embryology goes into improving the implantation rates. So we picked up this topic, and the Chhattisgarh people have been very enthusiastic. Hats off to you, Dr. Anuradha. So, my co-moderator, Dr. Veronica, has been quite participating and quite enthusiastic over the past 1 week. So I think it's time to start the session now. And over to you, Dr. Anuradha.
Yes, yes. Now I'm handing over to Dr. Sudha to start the first session.
Yeah, Dr. Sudha needs to be unmuted. She's writing a message in the chat box.
She's already unmuted.
She's already unmuted. Okay.
Just a second, ma'am. बीच में नहीं आ रहा? Okay. Good evening, everyone. A warm welcome to all the faculties and delegates. Today, IFSCG, in association with SIG Embryology, is here to present an insightful webinar on how to optimize implantation rate. Optimizing implantation rate has always been a topic of interest for all. There's always a demanding role of both the clinician and embryologist to increase the implantation rate and tackle recurrent implantation failure. So, without wasting any time, I would move forward for the first topic, technique of embryo transfer by Dr. Anupama. For this, I would like to invite Dr. Sangeeta Sinha ma'am and Dr. Kalpana Singh ma'am to chair the session. I think, ma'am, Kalpana ma'am, you have to chair because Dr. Sangeeta Sinha ma'am has not joined till now. So,
Okay. Can I have the CV of Dr. Anup?
Yeah, I'm trying just, ma'am.
Hello, Dr. Anuradha. Hello, Dr. Sudha.
Yeah, ma'am. Hello,
There
ma'am.
are network issues. I am trying to log in from the laptop, but meanwhile I have joined from mobile because I have already been late.
So let me introduce Dr. Kalpana Singh ma'am, though she doesn't require any introduction. She's the founder, joint secretary of IFS Bihar chapter and a very active member in all the events. So over to you, ma'am.
Can I have CV of Dr. Anupma?
Yeah. Hope, ma'am, it's clear to you.
Actually, some names are written, but presentations are being shown, but you have to select, na, Dr.
Yeah, this I have already displayed.
The CV. CV is not being displayed. You are able to share the screen?
Yeah, ma'am.
It's okay, ma'am. मैं अपना screen share
Yeah.
कर दूं?
हाँ,
पहली slide पे है ये।
आप अपना इंट्रोडक्शन आप share
आपको मिल गया, मैम?
मैं आपको ना अपना slide share कर देती हूँ।
शेयर कर दो या
हाँ,
उससे मैं बता देती
मैम मैं कर रही हूँ।
सेव मत कर, मेल कर।
Good evening all. First of all, I would like to express my thanks to Dr. Anuradha for having invited me for this important activity and allowing me to be the chairperson of the session. It's glad that I am chairing the session of Dr. Anupma Ravi Futela. She'll be going to speak on techniques of ovum pickup and embryo transfer. And she is graduate from KGMC Lucknow. She has done masters from MAMC and she has done fellowship in reproductive medicine from Singapore. And she is owner and senior consultant at Futela Hospital. And gifted first IVF baby to Kumrao region. Actually, can you make the screen bigger?
Yeah,
Actually,
yeah, ma'am.
it's
Yes, ma'am. I'm doing it.
on.
Oh,
Slideshow.
yes, ma'am. Is it okay? It's visible, ma'am.
I can read. So she's a primary member of State Surrogacy Board and she is Best Gynecologist in Uttarakhand Award. She got this award by Chief Minister in 2020-22. And she's She has got many awards, prestigious awards. And over to you, ma'am.
Thank you, ma'am. Thank you for those kind words. इतने सबकी जरूरत नहीं है मैम, बड़े बड़े लोगों के बीच में बैठी हूँ.
अरे अरे कुछ नहीं, आप भी बड़े हो मैडम, ऐसा नहीं है. वी ऑल सेम प्लेटफॉर्म.
Okay. So
मैं करूँ?
हाँ, मेरी स्क्रीन क्या विजिबल है?
Yeah, screen is visible, but make it slideshow. So it will
Yeah,
be.
I'm making that. I'm doing that. Don't worry. Okay.
Yeah, now it's better.
Okay, fine. So thank you, Kalpana ma'am. And at the outset, a big thank you and hugs to Anuradha, my close friend from Singapore. Our unity started there at the Singapore training time. And another big thank you to Dr. Sarab. It's been an honor, Sarab, to be associated with you and to have you on the same platform as I am. You people have done a great job, and I'm so proud of all of you. And thank you. First of all, start with the academic session for today. And I had been given topic of embryo transfer as well as pickups. So I told Anuradha that I cannot do justice in 20 minutes to both the topics, although I have prepared both the topics, but I'll stick more to embryo transfer because that is what I felt was more important for the current flavor of the webinar. But if time will permit, I'll go with the ovum pickup as well. So I'm starting with this embryo transfer thing. And as we all know that embryo transfer is the final and the crucial event, and it's very important where we are depositing our embryo, how we are depositing, who is depositing, and the technique. There has been study. When I was going through the literature, the review says that same surgeons, same place, same setup, and the person who's depositing, consistently few people would give better results and some would give lesser results. So definitely there is a role of the technique as well. When I was undergoing the training for IVF pickups and everything, I realized every step was taught to me hand by hand. My teachers used to give me, but the embryo transfer, I was never given. I was just told, I observed, but I never inserted the embryo myself. So when people come to me for training, again, the same thing happens. I see that I give them pickups, I give handheld them and doing that, but ultimately embryo transfer mocks I'm giving, but final embryo transfer I'm not giving. So we all understand that it is the final step, and at what pressure you are pushing, how you are pushing, that gentleness which has to be there. Everybody wants to do that. And gradually, it doesn't have a good, great learning curve. It is not a technically very challenging procedure. It is very easy to learn it. But the finesse you have to develop, it's like an art which you have to develop, hearing all the things which all of us have over the years compiled. So most of the evidences which I have produced here are from the Gardner, which is the textbook of ART, and the ASRM guidelines, the updates of 2022. That is my main forte here. And just a second. Not able to see my screen. Hold on. Okay. So what all evidences say, this is just the first slide, and after elaboration, this is my last slide as well. So there are few grade A evidences, and one of those evidences is that ultrasound assistance definitely helps. And Transabdominal ultrasound has been the gold standard, but sometimes in some centers, transvaginal things are also coming up. So with passing time, probably with our mocks, we should try to practice with transvaginal assistance as well. I have personally tried it a couple of times, but along with the Cuscos, I'm not so happy with the placement. So that is why I'm still not using the transvaginal assistance, but this is the future developments are going to come there. And transabdominal ultrasound is a standard, all of us know. The problem with transabdominal is that patient needs to have very good full bladder, which makes the lady uncomfortable many of the times. It can help you in the angle correction. So both plus minus are there. In difficult ETs, if we do it transvaginal, we can probably see it, since it's closer, so we can probably see it better, and we can have better visibility. So if that can come with time, it will be a good thing. Soft catheters, all of us know that that is the standard rather than the firm catheters, and bed rest obviously is not required. Then the grade B evidence which is there is for cervical mucus removal. There is a full slide to cervical mucus. There are positive to it and there are negative to it. When we do it excessively, it can become traumatic. The blood can be there. It could be bad. And when we do not remove it at all, the excess mucus can clog our catheter. So we have to keep a balance over there. But many such studies have not actually supported that cervical mucus removal is to be done. What I would suggest is that it has to be done. Excessive mucus is to be removed, but it is not to be very diligently removed that every drop and whim you have to aspirate, because that can be traumatic and that blood and all can come over there. The location of the embryo placement, some would say 1 centimeter below the fundus, some would say 3 centimeter below the fundus, some would say 2 centimeter. So that's still a gray area, but definitely most of the studies say that lower ones are better rather than higher embryo placements. So the middle cavity is the final answer. And regarding the timing of the withdrawal, some say that you should withdraw after waiting for 30 seconds. Some say you immediately withdraw. Some would say you wait another 60 seconds, but no, the evidence says that there is no need for extra waiting time after you have deposited the embryos. And the small evidence which is still there is about the rate of the injection. It doesn't have to be very fast. It doesn't have to be very slow. The length of the procedure, obviously, if it is a very long, more than 120 seconds from the embryo in the incubator to the uterus, if that timing goes more than 120 seconds, then it is a problem. But again, the evidence is just C grade. Some would say that you have to rotate your catheter while removing. So that is again not 100%. It's C grade evidence. I personally always practice rotation while withdrawal. And the position of the outer catheter, some would say that it is okay to go beyond internal os, and some are very particular that it should be kept at the internal os. So it's a C grade evidence that you should keep it at the internal os. Then the evidences about acupressure, massage and everything, that I would further elaborate what the evidence says. This is from the ASRM guidelines. Massage, acupressure, nothing has any role. Analgesics, it's okay. I mean, there is not a strong positive and not a negative. So if piroxicam 10 milligram, some people routinely give it. So it is okay if you are practicing that. Anesthesia, general anesthesia, there is no good evidence as yet. I personally feel that in difficult patients, general anesthesia could be a boon, where patient is very apprehensive. You are so much at ease, patient is relaxed. The stenosis element is obviously, but actually the conclusion could not be made because not enough studies were available. Antibiotics, again, there is no hard and fast rule that you have to give antibiotics. Some people are giving and they vouch for it, but evidence doesn't support it. Powdered gloves, again, some would say that the talcum presence is very bad, but actually there is not enough study available for that. So the answer is still not there. We should wait after pushing the embryos. We should wait for withdrawal. No, we don't know as yet. But the thing is that evidence says there is no need to wait. You can come out as soon as you have pushed the embryos. The presence of blood or mucus after on the inner catheter while you are evaluating, does it give a bad sign? It is very sad when any clinician watches a mucus or blood on the inner catheter, but then evidence doesn't say you should not lose heart. I'm sure all of us have had pregnancies even when we have seen blood on the embryo catheter. It is ideal that you should not have it, but the evidence doesn't say that it is a very ominous thing. Obviously, you should start and avoid that. These are the steps of embryo transfer. I have a video, so I'll just rush with it. And mainly the steps of embryo transfer is that we have to take the patient's consent. We have to counter confirm that the patient is the same, the embryos of which patient we are getting in, and the file of the patient has to be cross-checked. And in hospitals where there is number, UHID number of the patient, that should be cross-checked. The catheter selection, obviously it has to be the non-toxic and the soft ones. The ideal situation when, since we are doing transabdominal scanning, the patient's bladder should be full. We should clean the vagina, and there were some people who were saying initially povidone iodine they were using, but now it is absolutely in the dustbin, and we only clean it with the saline these days. And some people would want to scrub it at the end with the media. That's up to you. But purpose is just the insertion has to be near the os. That area is important, and rest of it is not really important. So it is ultimately the cervical mucus which is we are concerned with. And cervical mucus, some would want to clean it while cleaning the vaginal toilet, and a major amount of cervical mucus would come out then. And if required, with the 1 ml syringe, you can aspirate it and then go ahead with the further procedure. The embryo loading technique, it's very variable. Some would load embryo by the traditional sandwich method. That is, they would take media, then air, then embryo with media, then air, then again media. So that's the traditional sandwich method. Most of the centers, I would say, that have adopted their own. Our book, Gardner, says something else. It would say they would take media followed by embryo with media and no air in between, and then they push it. At our center, we take directly embryos with media. We do not even flush the catheters beforehand. Most of the centers do flush it, but at our place, we don't even flush it. We just take it, the embryo with the media, as little amount of media as possible, and then followed by a little amount of air, and then we put that in. So these are small varied practices, which with time we evolve. We had been practicing something else earlier, but now this is our standard practice. So then the embryo which is loaded, the embryologist has to, we have a lot of embryologist friends here on the group, and they would probably understand that better, that how important it is to get those embryos. And usually it is a good idea to have another assistant, if possible, who would escort you along with that and open the door or the passing window. That would be a comfortable thing to do. Some places have very small windows. So through that small window, the passage of catheter is usually not very comfortable, and they would want to go through the doors. So that you have to adopt over the time. Then the embryo, where it is to be pushed, it is usually 1 to 2 centimeters from the fundus, and it is a good idea to do mock ETs earlier and have the idea where you should place the embryos, because in some patients the uterus or the cervix would have a different shape the entry would be different. So it's better to do that, put that in your notes so that it comes handy when you are actually doing the transfer. Because this difficult group is the one in which one sometimes opts for general anesthesia as well. Once the embryo is deposited, then you have to withdraw it slowly, but sudden withdrawal. Once you push the embryo, you rotate and withdraw. But it is suggested that once you are withdrawing, it should not be very immediately and very strong pull, because that creates a negative pressure. So it has to be rotated and gently withdrawn. If it is very strong pull, the negative pressure can withdraw the embryo to a lower portion. Then that embryo, that catheter is handed over to the embryologist, and they would flush it again and check it. And then that is how we will conclude it. And usually at our place, we'll give 5 to 10 minutes to the patient, and then she's off and she can pass urine if she wants to. Okay, so there are some videos, small videos, which I would want to play.
Okay. The first thing which, while doing embryo transfer, is that you have to ask the name of the patient. Once you've confirmed the name of the patient, then this is the set of instrument which we usually require. Naam kya hai beta aapka?
So I'm basically enumerating what all different instruments I would want to keep in my embryo transfer tray. There are 2 instruments mainly, which I'm highlighting, and I've shown it here.
So this is the set of the linen which we have, and the only instrument which we really require is a cuscus. That's it. And sometimes, and a sponge holder, of course, for cleaning. So we need to use some sponge holder to clean it up. And 2 sets of instruments which I wanted to specifically. Okay. The first thing which, and a sponge holder, of course, some sponge holder to clean it up. And 2 sets of instruments which I wanted to specifically tell is, which I keep as a backup, is a different kind of sound. This is the normal sound, and these are the small, very thin dilators. This is different from Hager's dilator, as they are very thin in the dimension. It's probably 1 or 2 millimeter in dimension only. And there's another thing which is known as a stillet. So this is my EB curve, and the stillet which is inside this is sometimes very handy for me in cases of difficult ET, which I use to sound when I have to make my outer catheter stiffer. This is a very useful adjunct to your ET tray.
Okay, so that was just about the stillet, and many companies probably give those stillet also for the outer catheter to make it stiffer and a better negotiation in cases of stenosed osses. So that everyone should have that as a backup. And this the thin dilators which I have shown is also thinner version of a sound, which sometimes comes handy. I usually use them if required at the time of mock, and when I know what is the direction, so then at that time in the outer, I usually put that stillet, and then I negotiate the outer and then withdraw the stillet. We do not cross the tip of the stillet, would not cross the outer catheter. I do not want to cause the injury with the metallic thing in the cervical canal.
Is aligned in abundance.
This is just a
according
wash,
to the
big wash.
Basically, I want to clear off all cervical mucus from the cervix. And I just want to disalign in abundance. Make sure that the temperature is according to the weather and it is comfortable to patient's body. And putting inside the cuscus, collar this vagina properly. This is the ET catheter, and this is the outer of the ET catheter. I'm going inside the cervix. I'm holding it. I have gone traversing the inner. This is the ET catheter, and this is standard Cook's ET catheter. This is the outer of the catheter, and this is standard Cook's ET catheter. This is the outer of the catheter, and this is the inner catheter. So when we are using this catheter, the primary thing which we need to know is that the marking of this.
I'm sure this is very boring for all the knowledgeable people. This
Side,
is just a marking which I'm telling.
Is when we are flush here. Once we've entered one mark, it is 1 centimeter, 2 centimeter. The catheter is to usual standard length. And if you have done your mock ETs earlier, you know where to place this stopper. This is the stopper, and this is the white marker. So sometimes you have to pull back your white marker. There are many ways by which people load their embryos on the inner catheter. Usually the embryologist holds it like this, puts it in the media. This is coincide, because you have to be very, very vigilant about the fact that this cervical length assessment has to be proper. Once you are inside the endometrial catheter, usually the embryologist holds it like this, puts it in the media, stabilizes his hand, and then sucks the embryo inside, and the embryo comes rolling along with the media. It comes rolling inside it. There are people who would first flush this inner once with the culture media. They take the culture media inside and outside, they flush the catheter, and after that, they start loading the embryos. This is not our standard practice. We don't flush it. We used to do it earlier, but now we don't flush it. We directly take the inner catheter. First, initially, we take around 15 to 20 microliters of plain media, and then another 15 to 20 ml of media, and then a little bit of air. This much of air, this much of embryo, and this is the media. So that is the total loading, and the embryologist brings this for insertion. There are many ways by which. So while doing the embryo transfer, the embryologist just gets the inner catheter, which lies with the embryologist. Usually, they keep it here at the heated surface, just that they want it to be little better than the room in those embryos which are to be transferred. Dish. They're going to select the embryos which are to be transferred. So they are loading those embryos which are to be transferred. And the embryos which are picked are shifted to the dish. And in this center dish, they have inserted the embryo, which is finally to be inserted in the patient's body. Now, the embryos which are resting here in this media are going to go inside. First of all, you take the syringe and load a little bit of air So they have taken a little bit of air and then they have attached it to the inner catheter.
It has to be very firm
Now
attachment.
they have loaded they are loading the embryo. Look at the way they are holding it. This is the position by which they have stabilized their hand. And now they are loading the embryo. The crux is you have to take as little as possible amount of media along with the embryo. Just for your information, this is the amount of media.
So we keep it as low as that.
So while doing the embryo transfer, the embryologist just gets the inner, just to show how they are loading. Let us see it on the screen. This is the embryo. And once she's applying the suction force, let's see how the embryo rolls it and gets inside the catheter. That's it. View is View is inside and just to show, the embryologist is getting the embryos. The assistant will open the door and she will tell us whose embryo is this. She will reconfirm that the the embryologist is.
Okay, so that was just a small, I was doing a mock ET and then I had shooted it. It was not the actual embryos. And they were just one of those discarded embryos which we were keeping for the shooting. So a word about cervical mucus. As I had already mentioned, that mucus can become a problem because it can cause improper placement of the embryos by blocking the catheter tip, and sometimes it pulls back the embryo from the expulsion site, and also the cervical flora can go inside and contaminate the cavity. But if you are too diligent and do excessive mucus cleaning, that it can cause bleeding, and the vigorous ones can even stimulate the uterine contractions. You can do cleaning by cervical swab, by aspirating it, by cervical brushes. You can use media to do the cleaning. They are just very varied practices and nothing is standard. We have to evolve I personally would say that at one point of time, I was very, very into cleaning, and now my cleaning has reduced a bit. I would do just the excessive amount is what I would remove, and not the one which is really sticking inside, because I realized whatever we are cleaning is more on the external os. What is in the canal, we cannot be 100%. We are not able to clean it 100%. So there is no point pushing in too much there, because as it is तुम्हारा external जो है वो cervical canal cross करके internal os जा ही रहा है. Then what are the potential negative factors and how would we optimize them? Uterine contractions are something which is the worst thing to happen. So what all things we already are doing is we are loading the patient with progesterone, the vaginal, the injectable, all sorts of things are given. There is nothing standard. Everything is okay as long as, because progesterone is a uterine relaxant. We do practice atosiban injections also in the patients in which we do find the peristaltic movements. Paroxycam usage by NSAIDs is also used by many centers. We got to be very gentle, and as we say that too much of cleaning, too much of holding the cervix, that can cause uterine contractions. We should also try to avoid touching the fundus with the catheter. We have to be depositing it in the mid cavity, because that would also avoid uterine contractions. Obviously, soft catheters are gentler on the uterus.
Dr. Anuradha, please stick to the time.
Okay, madam. I'm Anupama, ma'am.
Oh, sorry.
It's okay, ma'am. It's okay. Then cervical mucus removal is not very important. So uterocervical negotiation has to be gentle, and ultrasound's role is there. Sometimes you would want to do hysteroscopy if required earlier. Then few good practice points. The embryos should be expelled, could be expelled in as many as 42% of the cases. Ectopic risk is definitely higher in IVF ART practice as compared to normal population. Mucus we do not remove. Mock up till 5 days prior, 3 to 5 days prior, it is not deleterious. If the cervical stenosis is there, then laminaria tent insertion should be done early on and not on that particular day. If we have to use tenaculum or Ellis for some reason, ideal is that you should apply a bit of local over there and then apply that. And what is the optimum location? That is still not very clear. Loading technique I have already explained. Glue, embryo glue, it is not universal, and still more studies are required. The studies have been very inconclusive and not of any advantage in most of the studies. These are various embryo glue techniques. Retained embryo, if it is there, then the final word is that you should push it back and not think that that embryo would not implant. You must push it out again. How to avoid that? We should aspirate media prior to taking the embryos. I also use a little amount of air behind in the syringe to avoid having that problem. And while removing it, it is a good idea to rotate and maintain the pressure and then take out your inner catheter. That would avoid retention of the. That's it. And HCG infusion role, it was at one point of time very popular, but even the recombinant version is not supposed to be good, because ultimately what is secreted inside and which helps in implantation is hyperglycosylated version of HCG and not the commercial version which is available. So there is no point adding the HCG infusion earlier. And bed rest rule, obviously it is not there because it's ultimately a potential cavity. So risk of ectopic, all of us know, is there. So as much as possible, uterus should be relaxed. That's it. Vaginal progesterone, latest is that vaginal progesterone are not, they give peak, and injectable progesterone are more coming back more into the practices. Estrogen exposure, if it is for very long duration, that also causes increased peristaltic activity. That was just the same slide which I have repeated here about the evidence. Thank you, the whole team of IFS. Thank you for making me part of it. Sarab and Anuradha, thank you again.
Thank you, ma'am. Really, it was very good.
Thank you.
Thank you, Dr. Anupama.
I'll stop sharing.
आपने अपना QR कोड भी साथ में लगा रखा है स्लाइड्स पे, just a joke.
Very nice lecture, Dr. Anupama.
Very nice lecture.
Very nice.
Thank you, madam.
You covered
Very
almost
nicely
all the
simplified.
points, Dr. Anupama. It was really nice listening to you. I just wanted to know, do you use antispasmodics before embryo transfer as a practice, or you don't use anything?
Ma'am, I do give pyroxicam to all my patients.
Yeah, because study says that pregnancy rates improves a bit.
Pyroxicam I usually start a night before. Morning also patient has been taking it, and a night before also. And progesterone also, one extra shot. Earlier, I'm not giving, even in the natural cycle transfer. I do a lot of natural cycle transfers. I don't add any progesterone earlier, but on the day of transfer, I do give a morning progesterone dose. And if after that, when I reach the OPD and still activity seen in the endobiometral junction, I would also add a atosiban. That is, I would say, so 1 out of 5, I do add atosiban too.
You have used it, or you are using it, atosiban.
I'm using it very commonly, very commonly.
So do you find that pregnancy rates are?
I
get
would
better?
not vouch for that, no, madam. But obviously, the endometrial relaxation definitely happens after giving a tocilizumab.
Only self-satisfaction we will get. That's all. I don't feel pregnancy.
मुझे वो मूवमेंट देख के एक्सपल्शन का डर लगता है, तो इसलिए आई गिव टॉसिबान. उससे रिजल्ट में फर्क आता है या नहीं आता है, आई रियली, मुझे फाइनली ये लगता है मैम कि रिजल्ट एम्ब्रियो ट्रांसफर में इज मेनली, आई ऑलवेज टेल माय पेशेंट, बीज और खेत. It is ultimately when the embryo is good and the lining is good, ultimately we get results. Otherwise, blood से loaded catheter में भी I have seen results, and sometimes even with mucus also. So
Very
खेत और
matters is good embryo and a good endometrium ultimately.
yes, ma'am.
So
Ma'am,
thank
do you
you.
like do you like frozen embryo transfer or fresh embryo transfer? What is your
I would say
experience?
99% I'm doing frozen transfers only. Fresh is only rare when I have a single embryo and levels of estrogen and progesterone are very happy, very poor reserve patients and not so good embryos. Then only I go for fresh transfers.
What is your
ma'am,
result about the natural cycle transfer or FPT, like HRT, after HRT?
If possible, if at all possible, I give extra energy and time to the patient to get a natural transfer, madam, because I have seen ultimately the obstetric outcomes are definitely better when I'm doing natural cycle transfers. Also, in those patients in which I'm not getting good lining, I have so many times seen that natural estrogen production would give us a better lining, and artificial estrogen patients, sometimes some people are giving 8-10 tablets also of estrogen. I personally feel that it is not really required that high a dose. TDS max, people do get results with BD estrogen as well. So TDS dose is, I think, enough, and no extra dose is really required. It is rather better to change to a natural estrogen if it is possible with the patient. Now, of course, sometimes it's a bad PCO and you cannot do it. That's a different matter.
We too are switching over to mild stimulation or natural cycle more. Only in PUR patients, there we go for HRT cycles. But because corpus luteum helps a lot
Yes,
in maintenance of pregnancy, and all the complications are less, like PIH and macrostimulation. So preference is for mild stimulation or natural cycle.
Thank you. Thank
Ma'am,
you.
for
Thank you.
TVS guided embryo transfer, do we need an illuminating catheter?
Ma'am, TVS
don't
जो
think.
मुझे problem आई, I have tried it. There is a cuscose already inside, and putting a probe along with that, मुझे उसको maneuver करने में problem आती है. Cuscose भी है, उसमें probe भी है. I don't know how they do it. If you remove the cuscose, then I am not so sure that my external placement is perfect. The article which I read was, they say that they remove the cuscose and they leave the external at that place and they check it with the transvaginal probe. So I'm still to develop that art. It looks, when I think of it, it looks okay to me, but I am yet to practice that.
I feel we should use sim speculum. When you use, first you use the spring speculum, hold the, then you take out that lower one speculum and put the transvaginal probe. Then it will be more visible and it will be
Before
easy.
the same speculum, that means we have already put in our external, right?
Yeah.
मुझे ऐसा लगता है, जब when we put the external, then when we are removing the speculum, either Sims or Cuscos, at that time, it is very important to be fixed on that.
That should be only done during difficult transfer. Transvaginal ultrasound is used only in difficult transfer. Like we are
That's
not.
fine, but if it is brought into common practice, with time, मुझे लगता है हम इसको सीख लेंगे अगर, तो हम शायद इसका better use कर पाएंगे. अगर हम सिर्फ difficult के लिए करेंगे तो हमारी difficulty आसान नहीं होएगी. वो common practice होनी चाहिए, तभी वो difficulty आसान होएगी.
Then, madam, in those cases, we should be using normal saline instead of that gel, na?
What gel, madam?
For lubrication, in TVS probe,
Oh,
we
yes.
have to use, na?
It should
Definitely.
be
Oh,
inside.
yes, definitely. It
It is
has to be
normal
saline.
saline only.
Like in pickups also, what do? We don't
Normal saline.
put any.
Yeah.
It's the same, yeah.
Okay. So we'll move on to next session.
Thank you.
So it was a beautiful presentation, ma'am. Coming to the next topic, it is idol culture, condition and techniques by Dr. Pooja Avasthi, ma'am. So I would like to invite Dr. Prakriti Verma ma'am and Dr. Shushma Verma ma'am to chair the session. Dr. Prakriti Verma ma'am is the director of Vardhan ICSI and IVF Center, the first IVF center of Bilaspur. She is the ex-secretary CG IFS 22 to 24. Dr. Shushma Verma ma'am is the director and consultant, Dr. Sarvodaya Hospital and Maternity Center and Test Tube Baby Center. She was the president RMS 2022-24. Over to you, ma'am.
Thank you, Dr. Sudha, for the kind introduction. As we all know, the ART laboratory is the most important component for the success of any ART program. And the physical arrangement, design, and equipments have to be carefully organized. And it is the responsibility of the ART laboratory to ensure a stable, non-toxic, pathogen-free environment with optimum parameters for oocyte fertilization and embryo development. So it is a very important thing that we have ideal culture conditions in our laboratory. And to know more about this in detail, I invite Mrs. Pooja Avasthi. She is going to deliver a lecture on ideal culture conditions and techniques. All of us know Mrs. Pooja very well. She is the scientific advisor and chief embryologist at Sitaram Bharatiya Institute of Science and Research, New Delhi, ex-director academics and embryology at IC. Received IFS Achiever Award 2022 by IFS. Received ISAR Embryology Excellence Award 2023. He has received ISAR Youth Icon Award 2023. She has 10 years of experience in clinical embryology, and she has been author and co-author of around more than 15 books, chapters and articles in reputed publications, and she has a special interest in embryo biopsy and embryology. So over to you, Pooja.
Thank you so much, Sushma ma'am. Nice to see you again after so long. And thank you, Anuradha ma'am,
Thank you.
for joining hand for this SIG. We were very excited when we started. And
As we all know, you are the heart of the IVF and the pulsation is the success. So I feel
is
you
also-
people are the very important in IVF program.
Yeah, Pooja is also the heart of the CMA which we organize. She is actually taking all the pains to organize everything.
Yeah.
So,
it's under your
congratulations,
guidance
Pooja,
and
for all your efforts. Thank you so much. Yeah.
thank you.
Thank you.
So before starting our presentation, I would like to thank IFS, Dr. Shweta ma'am and Dr. Pankaj Talwar sir for making me capable of handling such tedious task. And obviously, Dr. Sarapri sir, with his guidance and advice, we are now here to do such academic studies and academic sharing of knowledge. So I would just going to share my PPT, and I hope it will be visible to all of you. In case it is not, please let me know. Is my PPT is visible to all of you?
Yes.
Yes, sir.
Thank you so much, ma'am. So today's topic is ideal culture conditions and techniques. Although it's a very, very big topic, and I would take 10 hours to talk about just the culture media and the techniques. And itself, incubator may take 5-6 hours. You all know it's a very, very wide topic. But still, I have narrowed down few points which are really very important while we practicing and culturing our embryos. So I'll start with what we are going to learn today in this 20-minute session. So we will be knowing about the component of embryo culture system. So number one is incubator, as we all know, is the heart of the lab. And the second is the culture medias. So incubator, we are not going to discuss about. Yes, culture media, I will just touch upon the basic ingredients, which are very, very important and crucial for the embryo development. And then we will move on to factors affecting culture conditions, which will include the VOCs, lab air quality, handling time of these gametes, media gassing, temperature, disposable, which we are using in the IVF lab, type of dishes, dish preparation and volume of media, pH of media, osmolality of media, how to cover oil, which oil should be used, and of course, concentration of gases, which gas is very good or which gas should not be used and in what concentration, so that we can get the desired outcome. So it's just a basic structure, and I want you all to focus on only two things. First thing is the concentration of oxygen. If you can see, there is a fertilization site in the oviduct where the fertilization and the cleavage process happen. Let me take my highlighter. Laser point is fine. So I just want to focus you all here that at the site of fertilization and the cleavage site, the CO2 oxygen concentration is 7%. And at the site of implantation, where we can say morula or our day 5 embryo roll down to endometrium, there's only 2% of oxygen. This is one first thing which I want you to notice. The second thing is the energy substrate which our embryos use. So first day 0 to day 3, they use pyruvate as their energy substrate. And later on, it is glucose, which actually initiate the compaction and then the differentiation of embryo into trophectoderm and inner cell mass. And finally, it implanted. So these two things are very, very crucial. And whatever media we are using in the lab, they are based upon only this theory. So we are trying to copy or mimic the internal environment, in vivo environment, into in vitro practices. So how we can say what is the role of culture media and what culture media does to our system? So culture media are an essential part of culture system that aim to minimize insult and stress to the gamete and embryos. They provide optimized in vitro environment. Culture media provide a balance of ions, energy substrate, and nutrients, safeguarding the best possible clinical outcomes. Culture media is influenced by many factors, including whatever I already said, air quality, temperature, and all lab parameter, including the expertise of your laboratory staff. Okay, so this is the basic composition of culture media. Don't worry, I'm not going to bore you about all these big stuff, but yes. So now you all know we have two types of culture media in the market. One is single step culture media and the another is the sequential culture media. Single step culture media advocate let the embryo choose whatever it wants, while the sequential culture media always says back to the nature. Whatever is present at particular site in vivo, they are providing and making the media as per the. So we can say sequential culture media is more stage specific culture media as compared to single step culture media. I just want to have your attention on the glucose, lactate, and pyruvate because these are the energy substrate. So one thing we have to learn, day 0 to day 3, there's always pyruvate which work as an energy substrate. So whatever media we are using in sequential, we have to check about whether the pyruvate and lactate are optimally present or not. And later stages in the blast media, I'm talking about the sequential, then glucose concentration is always higher. Then essential and non-essential amino acid. So non-essential amino acids are always required during pre-compaction, which means day 0 to day 3. And then essential amino acid play role in the compaction, post-compaction embryos, like morula formation, cavitation, and the differentiation of the cells. Now, just two more points I want to talk about this. I just want to take this amino acid glutamine. Glutamine is very important key ingredient, but at the same time, it's a kind of double sword. If glutamine is because the ultimate product of glutamine degradation is ammonium, which is very, very harmful for the embryo. So what we now culture medias are using different form of glutamine, which is more bioactive, or we can say L-alanine glutamine, L form of glutamine. Then just talk about this EDTA. EDTA work as a chelator. Basically, it chelate heavy metals. And Last, serum albumin. So we all know serum albumin is the most abundant in throughout the cavity in vivo, and we are trying to mimic that. So generally all the culture medias have 5 to 10 mg per ml human serum albumin in their composition. So what is the objective of our culture media? Culture media must support primarily sperm function, which is motility and capacitation. They support cleavage stage, all the embryo development. They also support genome activation and also cell differentiation. So having said that, what is our endpoint? What we want from these culture medias? We want a good embryo development, good blast formation rate, implantation rate, and ultimately a healthy live birth and healthy baby. This is the basic journey in terms of if you talk about the biochemistry and genetics and all the morphokinetic things of the embryo, then it starts with the appearance of 2PN and 2PB, and then it start cleaving in 2 to 4 cell. Accordingly, on day 3, it's 8 cell, day 4, compaction is started, and day 5, there is a differentiation of ICM and TC and fluid accumulation. In this developmental process, there's few events occurs and they should be supported by the culture media. So we are focusing that these whatever culture medias we are using and the way we are using this will support all those events. And these events are morphogenesis, metabolism, gene expression, and differentiation. So gene expression, because initially when day 0 to day 3, the embryo grows and divide under maternal genome. And after day 3, it is always, the development is under embryonic genome activation start, and the component divide now in de novo synthesis pattern. Now we discuss few very, very important things about what are these factors which are giving, affecting the culture condition and giving us sometimes bad or poor quality of embryo, other than if the quality of embryos and quality of gametes are not good. So what are these extrinsic factor created by or during this process of embryo culture? So there's total 175 factor, if you believe, starting from the oocyte retrieval, sperm preparation, and whatever you perform, PGT, anything. So there's 175 factor. Obviously, we cannot conclude all those 175 in this one go, but yes, I'm just taking care of few factors, which is like gassing of media, which we all know it is very, very important to gas your, properly gas your media. Later slides will definitely describe why gassing is important and how it incorporates good culture conditions, then incubator temperature and gas concentration. Exposure of gamete to the microscopic light is also very, very important. Heating surface has a very vital role, and handling time and pipetting time. There's a paper published and it says that pipetting causes a kind of stress activation protein in the gamete. So pipetting is also very, very important. Then again, air quality is always play a vital role, and obviously the handling expertise of the laboratory staff. So now we will start with the temperature, and temperature, everything is correlated. Nothing we can individually, we cannot learn anything individually. So whatever the dishes or plastic we are using in the IVF lab is very, very crucial, because we are growing our embryos in that plastic dish, and we have to be sure of few things, that these kind of plastic dishes should be flat bottom. Flat bottom because we need a consistent temperature. Lower temperature cannot result in a good embryo quality, as well as the higher temperature. So we are very, very particular about the temperature. So we should always prefer a flat bottom dish, optically clear dish, so that we can get a good culture condition and the temperature. Dishes should be designed to control heat transfer for temperature stability and for optimum manipulation and observation of ova and embryo while working. So we take out the embryos, we check the grading, we do the grading, we check the PN, and all these procedures, we are exposing our embryos. So it is the high time to check whether our heating surface where we are keeping our dishes, are they adequately providing the temperature or not, right? Then we always want a petri dish or a dish which is MEA tested. It should be non-embryotoxic, non-pyrogenic, and non-cytotoxic. Tissue culture dishes should be treated for a consistent hydrophilic surface. Why hydrophilic surface? Because we do droplet culture. So droplet should retain their shape. So the dishes should be hydrophilically coated. They should be gamma irradiated, and they should be very easy and handy to open. So packaged in a peel open, medical style packaging, and single packaging always welcome. But if they are giving multi-unit bags, then they should always provide us with reseal tabs. So while we are culturing our embryo, what kind of media where we are culturing our embryo? So as we all know, the physiological buffer of in vivo in all the fluids is 7.2 to 7.4. So obviously when we are culturing our embryo, we are exposing those embryo to a culture media which is having pH of 7.2 to 7.4. And how we can attain this pH of the culture media? It's very, very simple. We have to gas our media in the incubator, where incubator is set at a certain concentration of CO2, right? So pH of oocyte and embryo plays a vital role in maintaining homeostasis and regulating several critical metabolic and transport processes, including protein conformation and glycolysis. Most embryo media utilize a bicarbonate or CO2 buffer system to maintain a physiological pH of 7.2 to 7.4 in the culture medium. So the balance between CO2 concentration in the incubator and the bicarbonate concentration in the culture media determine the pH, and thus the embryo is exposed to. So all the culture media, they have a certain percentage of bicarbonate concentration, and when we expose these bicarbonate concentration to the CO2, which is present in the incubator, they kind of make a biochemical reaction and they stabilizes the pH. So pH is not simple to stabilize. It has its own phases. So whenever we aliquot or we keep our media inside the incubator, so pH is like initial few hours, it equilibrate, then it set at a particular point, and then it get stabilized. So equilibration time depends upon the diffusion of CO2 into the media and the timing of pH reaction. It also depends upon volume of media, how much media you are allowing for the gassing. If the media quantity is more, then definitely it will take more time to stabilize the pH. The surface area, the use of oil overlay, because sometimes we used to make the dishes in a droplet manner or with the more volume, and then we keep it for the gases. And even the type of lid, if we are making the making the dishes before a day prior to the ovum pickup. So these all things can influence this gas exchange and equilibration time. So there's a two type of pH. One is pHe and one is pHi. pHe means that external pH. External pH is of culture media, and there is an internal pH, pHi. Internal pH is of gamete or embryo. So they should be in an equilibration. So to maintain the pHi of the embryo, we have to maintain the pHe, which is the embryo culture media. So pH remarkably impact oocyte and embryos. How? So once we decided that we are going to do the ICSI, then we denude the oocyte, and then Once we denuded the oocyte, they cannot regulate their pHi, which is their internal pH. Then we have to expose them to a culture media which is balanced of pH. pH affect oocyte mitochondrial localization and developmental competence, oocyte metabolism, embryo metabolic activity, intracellular organization, and obviously overall embryo development. Rate of blastomere division, fragmentation rate, overall embryo morphology. And when we talk about the cryopreserved worm embryos, because they are cryopreserved, they also don't have the ability to regulate pHi just after the warming procedure. Then, so whatever stage embryo or gamete we are putting in the culture media pH is of crucial importance. It should be always maintained in 7.2 to 7.4. What other factors impact the pH? Why I'm stressing over pH? Because pH has a huge role in the embryo quality. So if we are talking about incubation time, many people ask me what is the ideal time. So ideal time is minimum 14 hours or overnight if you are allocating more much larger volume of media. But if you are making smaller dishes in a droplet manner, then minimum 5 to 6 hours is what everybody advocate. Now to talk about the altitude, although we all are the people, we are from the plains, but higher altitude have less barometric pressure, which means they need more CO2 in their incubator to maintain the desired pH. pH can be also changed by frequently opening the door of incubators. And also how you are checking your pH. It is also very, very crucial. If you are checking your pH with some inappropriate pH devices, then definitely you are getting a wrong value. The next thing after pH is osmolarity. These all the factors, if we conquer, we will definitely going to get the best embryo. So what is osmolality? Just to define it, osmolality of culture media can be defined as the total osmotic activity contributed by ions and non-ionized molecules to the solution. Or you can simply say the number of solid particles dissolved in a solution is called osmolality. So what is osmolality? The standard osmolality of all the media is 260 to 295 milliosmol per liter. And osmolarity much dependent upon the temperature. So there's a study where they have checked the osmolarity increase. So they taken few parameters like one is temperature, one is airflow, one is the drop volume, right? So they are saying if you are making your dishes on higher temperature, then while making the dishes, the osmolarity is going up, which means you are putting your embryos in already higher osmolality culture media, right? Higher osmolality will never ever give you a good embryo. Second, they check with the airflow. And with the airflow on, depending upon, I have seen in many labs, there's a very much blast pressure. So that we need to avoid, or we have to set the blast pressure at the medium level so that we can have the air curtain and we should not expose dishes too much, right? And next, the drop volume. So drop volume, if the drop volume is less than 40 microliter, then osmolality increase is too much. So there's a very good paper, although it is published in 2019, which actually depict unstable osmolality of microdroplet culture in non-humidified incubators. Because non-humidified incubators are warmer or they don't have any humidity, then the evaporation rate of media is more. And obviously, if the evaporation rate is more, then osmolality is going to on a higher side, and it will end up in not getting so good embryos. So osmolality is very, very critical to control. Little change in osmolarity can induce major part in embryo development. Osmolarity increased, development is decreased. So how we can create our dishes so that osmolality remains constant, or it should not, media should not evaporate much. So there's one answer to it, is we should control whenever we are preparing the dishes, we should have 22 degree temperature of the surface. This is one way. And second way, we can make little bit more oil layer on it so that the evaporation rate got minimized or reduced, and we get the good osmolarity of the media where we are going to keep our embryos. So there's an experiment by Cooper Surgical. It's an internal data. I took this graph from there. What they did, they took a 60 mm dish and they make a droplet size of 20 microliter with the single step media, and they put the oil over it, and they make the dish on the room temperature, not the 37 temperature, and then they, in a particular time interval, they checked for the osmolality, right? So blue is the sign when they took 20 microliter drop size and they overlaid with 4.5 ml of media, 4.5 ml of oil. And the green one is when they took 20 microliter of drop size and they covered these drops with 6 ml of oil. So after this experiment, they find out that when we cover our dishes with more oil, then the osmolality remains same, and or it increases in a very, very minimum amount. So that gave us very much insight that if we are going with a culture, micro droplet culture, then there should be more amount of oil over these droplets, so we can maintain not only osmolarity but also the temperature and pH. So oil also has a very crucial role in the entire culture systems. In the low oxygen conditions, we have a lot of talks here and there over CMEs that hypoxic conditions are very good for the embryo development. So this few scientists, they have made this experiment and they took low oxygen versus high oxygen and they cultured embryos on that. So they took 21% of oxygen, which is normal box incubator, and 5% of oxygen, which generally comes with the premixed gases, which you use in the benchtop incubator. And they find out that with the low oxygen concentration, they got good number of blast, not only good number of blast, but also the implantation rate and the live birth rate.
Pooja, sorry to interrupt. Can we finish it in a while? Because we are running short of time.
Yes, Shushma ma'am. So I have only 2 slides left. So now come to the culture techniques. So now we know this, we have 2 types of culture, group culture and monoculture. I have kept 1 slide for the group and monoculture. So in group culture, all the embryos secrete kind of paracrine and autocrine factors. They are actually help each other to grow well. And while we are using monoculture, the paracrine and autocrine factor, they get diluted. So we will not get the benefit of these factors. So, and then single step media versus sequential media, I will leave it for the panel discussion, or in fact the monoculture and group culture also. So just in the end of what is the take home message? So culturing human embryo requires attention to detail. Every parameter is important in IVF lab, not just few. Adherence to SOP and quality control are vital. Gassing of media, temperature monitoring, and choice of plasticware are of paramount importance. In the end, big journeys begin with small steps. Thank you so much for having me here. And this is my last. Thank you, Shushma ma'am, for giving me time.
Thank you, Pooja, for giving
Thank
such
you
a
so much,
wonderful lecture. And you have covered almost every aspect of culture techniques, culture media. Thanks a lot for a wonderful deliberation. As we are moving short of time, we are not going to have question answer session at present. We will discuss few questions in our panel discussion also. So I would like to invite again Dr. Sudha to invite our moderators and panelists for the session.
Thank you so much, Dr. Pooja.
Thank you, ma'am. It was a wonderful session. So coming to the next topic, we'll have a panel discussion on how to optimize implantation rates. For that, I would like to invite our moderators, Dr. Sarabpreet Singh, sir. He needs no introduction, but still he is the IFS and HRA certified senior clinical embryologist. He's the director at the Fertilis Academy and has been awarded for Best Convener SIG Group at Fertivision 2019. Our next moderator is Dr. Veronica Will, ma'am. She is the Secretary IFS Chhattisgarh 20 to 22, Joint Secretary IFS CG 2018 to 20. She is the Director of Dr. Veronica Will IVF and Fertility Center and Senior Consultant at NHMMI Super Speciality Hospital, Raipur, Chhattisgarh. Next, I would like to call our experts. Dr. Asha Jain, ma'am. She is the Director of Ma Sharda Hospital, Maternity Hospital. Then Dr. Pratibha Makhija, ma'am. She is consultant in ART and gynec endoscopic surgeon at Makhija IVF, Bilaspur, Chhattisgarh. She has worked as an assistant professor in the Department of OBG at PTGNM Medical College, Raipur. Worked as a clinical associate at Reliance Regenesis Center in ART, IVF and endoscopy, Mumbai. Our next expert is Dr. Sujata Pradhan, ma'am. She is she has done doctoral fellowship in reproductive medicine at CMC Vellore. She is the professor and head of infertility unit of IMS Sam Hospital, Bhubaneswar. Over to you, ma'am.
Thank you, Dr. Sudha. Dr. Sarabpreet Singh, would you like to take the thing initially?
Yeah. Please
Being
allow
the
me to...
being the head of the family.
No, I'm not the head. So, can you stop sharing the screen so I can share mine?
Yes.
So, we're going to begin the panel on how to optimize the implantation rates. It's a very important panel, and a lot has been discussed. Dr. Anupama was brilliant, and so was Dr. Pooja. And but we have some issues which have been unaddressed, so we'll take up those issues in the panel discussion now. So I would like to invite my esteemed panelists. So we have got Dr. Paulami. She is a fertility expert and currently working at Nova IVF, Raipur, Chhattisgarh. Then we've got Dr. Akshay Mahapatro with us. He's a senior consultant and I'm medical director at Shreya IVF Center, Bhubaneswar, Odisha. Dr. Jitendra is with us. He is also a consultant at Odisha. Then we have Dr. Pragya Suryavanshi. She's the director of SMC IVF Research Center. I hope all our panelists are there as part of this meeting. We've got Raghunandan. I can't really read, but he's a PhD. He's an embryologist. He has got a PG diploma in clinical embryology and ART. And he is working in Nova IVF Fertility Center. Then we have got our own Dr. Pranay Ghosh. He is a very famous embryologist as well as a clinician, and he's the director of Elixir Fertility Center, New Delhi. Ajay, I don't think Ajay has joined, but if he comes in, then he is the chief embryologist at Krista IVF. Pooja is one of the panelists. You have heard Pooja, you know Dr. Pooja so well by now. So we'll start with the panel. Just to introduce that science has progressed to a great level, and we know about...
One more panelist is there, Dr. Pratibha Tiwari.
Dr. Pratibha Tiwari is there. She is a consultant. She's
Yeah.
a consultant at Birla IVF here in Raipur. I welcome Dr. Pratibha.
So
Thank you, ma'am. Hello, am I audible?
Yeah, welcome, Dr. Pratibha. Sorry for missing.
Yeah,
See,
I'm associated with Oasis Fertility Raipur.
Oasis
Thank
Fertility
you.
Center. Okay, okay. Sorry.
So to begin, science has progressed to a great level, and now we understand the whole process of reproduction. We're able to perform, ART techniques outside the body. And we have simplified the diagnostic and therapeutic process like folliculogenesis, hormonal interplay, control, egg retrieval, formation of embryo, and embryo transfer. However, a lot needs to be learned about endometrial receptivity, a good embryo, how to define a good embryo, and ultimately the interplay between the endometrial receptivity and the embryo, which is influencing the great process, it's like a holy grail, the process of implantation. So how do you define implantation rates? It is defined as the number of gestational sacs divided by the total number of embryos transferred. It depends on embryo quality, which again is a full lecture in itself. Endometrial receptivity, which Dr. Veronica will take up as part of the panel discussion, and the ET technique. The ET technique has been beautifully described by Dr. Anupama, although we would like to take her opinion on some part of the lecture which he delivered. Implantation rates are an overall is there an indication of overall performance of the lab, and if that implantation rate is low, it's a serious sign of a systemic problem in the lab. So how do you calculate implantation rate? It is calculated by the number of sacs seen on ultrasound divided by the number of embryos transferred. If you're transferring cleavage stage embryos, the competence level is more than 25%, whereas the benchmark is more than 35%. Whereas if you take the case of blastocyst or day 5, day 6 embryos being transferred, the competence is more than 35% and benchmark is more than 60%. So when you talk about, how when you talk about the success of an ART cycle or the critical elements of an ART cycle, it begins with the patient, the stimulation protocol, the gamete quality, and then it comes to the lab. In the lab there are various parameters like Pooja said that there are around 175 variables which you need to control. We need to know about the whole culture system, which again Pooja has discussed in great detail, and the quality control and assurance program, which is controlling the lab as well as the culture system. Then we end up with a few good embryos, and then ultimately the process of embryo transfer and the luteal support, which is the most important. Plus, genetics also play a big role in the whole process. Dr. Veronica will be taking up genetics also. So over to you, Dr. Veronica.
So like sir has mentioned, there are three main important factors that affect implantation overall. The first one is the raw material, that is the gamete or the embryo quality. Now, a good embryo has better chances of implanting. And so most of the success evolves around these confounding factors, which when catered to will give better implantation rates. So my first question goes out to our esteemed panelists is, what are the various factors that affect the embryo, or we can say the gamete quality also? Dr. Pragya?
Yes, if we talk about embryo, it starts from the time we do oocyte pickup. So our protocol, what was the age of women, start from very early stages. So what was the age, how we stimulated, and what kind of oocyte we retrieved, then our culture conditions, and then how it became to embryo, what was how it became 3-cell embryo, and what was the grade 8 cell, and then the blast. What was the all condition? If all the thing is from the line it is in right, then we get the good embryo. So we need to start from very early at the time of workup. So
we actually need to start from the raw material side, that starts from the gamete, or that is either the sperm or the oocyte. So anybody would like to add over these issues?
Yeah, from the male and female side, what is the age of the patient and the ovarian reserve and their lifestyle factors like BMI, and also their addictions, if they have any smoking, alcohol, and any drug abuse, And apart from that, any coexisting gynecological conditions which might affect the female oocyte, like endometriosis if they have, or any risk of poor ovarian reserve, genetic factors that are affecting the gametes. And in the male side, if they have any occupational exposure which might lead to radiation, chemotherapy, or any disease like cancer, which might, or chemotherapy, radiotherapy, which they might have had for the treatment. And also medical conditions like diabetes can affect the sperm quality.
Right. So as she has told, the story actually starts much before the ovum pickup and the embryo transfer procedure. It actually starts from when you are selecting the patient. You have to select the patients, treat any confounding other factors, like if any addictions are there. She has enumerated most of the thing. Treat any infections that are there, possible associated factors, like any post-radiation patient or those kind of patients are there. Then most important comes the stimulation protocol. How you are choosing them depends upon the stimulation protocols. Then comes the ovum pickup and the embryo formation or the lab part of it. And finally, the embryo transfer procedures. So these are the various, sir, the next slide. Next slide. Yes. So these are the various factors that affect gamete and eventually the embryo quality. So treating and removing these factors, associated factors during the procedure, that is OPO and ET procedure, as well as treating the or managing the lab part of it, is very crucial for better outcomes. Next slide, sir. So what are the various factors that should be taken care of while choosing a perfect stimulation protocol? Dr. Polomi?
Hello, good evening, everyone. So, when we choose a particular protocol for a couple, we should see the age first of all. The patient profile, which includes age, AMH, antral follicle count, weight of the patient, and of course the drugs which we are going to use, whether those are only HMG or we want to do FSH and HMG cycle, depending on the hormones on the particular day two of the cycle.
Is that all? Something more we can add to it? What does the evidence say? What kind of protocols?
It should be an individualized controlled current stimulation. And we have to tailor it according to the needs of the patient.
AFC also important.
AFC shares.
Yes, so that comes under the biomarkers, two most important biomarkers that help us decide.
AMH and AFC.
Age, AMH, AFC, I always say AAA. All three things are very important.
Yes, so those three things are very important. More so important is the antral follicular count, or rather they are considered the active biomarkers. Antral follicular count.
AFC is very important.
Yes. So the type of protocol, what does evidence say? Definitely it says that we have to choose a protocol that is much safer. Safety is something that is being assured nowadays, now that the ART Act has also come. So type of protocol, what does the evidence say? How do we choose it?
Usually mostly antagonist protocol, but there is no difference between agonist and antagonist. And antagonist protocol is more safer. It is less time, and it is better. Ideally, antagonist protocol is better.
But then antagonist is also associated with lesser oocytes.
So here I differ that when there is poor antral follicular count and poor AMH and age is high, in such cases, I prefer agonist protocol when I'm seeing there are very less reserve. So here we can go for the agonist protocol also. And I get, in these cases, we get better number of oocytes and quality.
So we have
also,
a difference of opinion here. We have a difference of opinion here. One is saying an enter protocol. Dr. Pragya says for poor responder, she prefers to have. Anybody else would add
Madam, basically for poor responders, the suppression can be used with the long protocol. And in such cases, if the intact protocol is used, we can also go for pull-up through dual stimulation, which might not be
that is also an
acceptable
option.
through the ESHRE
So we
guidelines,
have
but still
a
we practice
dual
that.
stimulation protocol, right? So we
Yes,
are coming up with a third protocol over here. Now, anything in particular which is specific that will help us decide our stimulation protocol?
If I may add, can you hear me? From the point of view of an embryologist. So first of all, with regards to poor responders, let's talk about that. The emerging evidence is that with regards to the optimization of the number of oocytes collected and the synchronization of the cord, because with DOR patients, you have some follicles which will jump up by stimulation day 4 or 5. So in those patients, the long protocol gives you a uniformity of the cohort, and you may end up getting 1 or 2 more oocytes as compared to the antagonist protocol. I would also want to make a comment regarding agonist versus antagonist for all patients categories, DOR, normal responders, and hyper responders. Hyper responders, definitely, antagonist fares much better because of the safety. We need to be mindful now that we have grown up believing that milder stimulations and natural cycle IVF and all, they are correlated to better euploidy rate. We believe that higher doses of gonadotropin is detrimental, higher stimulation dose. But now the emerging evidence is contrary to that, and various studies which are solely focusing on the euploidy rate of the blastocyst across various stimulation protocols, they are showing that now our endeavor should be to maximize the number of oocytes collected safely. And there is no dip in euploidy rate if you go over the magic number of 14 or 15 collected. In fact, you are just accumulating more euploid blastocysts, even with in cases of hyper responders. So now our objective should be to maximize the number of oocytes collected safely. That being said, we have to definitely individualize our protocol based on the patient age, patient weight, patient BMI, and our typical starting doses are 187 or 225 or maximum 300. We don't have much to gain after 450. With that, we know. The other question is, sorry, in the thought of chain of the thoughts, I lost the second question that you asked. What was the last question, ma'am, that you asked?
So which one to choose? Which protocol? Particularly in
Depending
terms of
upon
safety and the trigger, the dual trigger protocol.
both the thing, I think it depends upon the reserve, ovarian reserve. If it is a hyper responder, then we will go for antag and agonist trigger. If it is poor responder, then we have both the option. But mostly in poor responder, I choose preferably agonist protocol. And there we have both trigger option available. Here we have only one trigger option available, HCG trigger.
So antagonist protocol for a normal responder or a hypo responder, you can give either a HCG trigger or a leupride trigger or a triptorelin trigger. If you are wanting to do some patient subcategories where you are anticipating lower oocyte yield, you are anticipating that the hormonal parameters are going to be fine, you may proceed with a fresh transfer, then you would benefit from a HCG trigger. Because we feel that once you're given a leupride or a triptorelin trigger, the salvaging of the cycle with 2000 or 5000 HCG is not so good, then you would be better off with a freeze-all cycle. That being said, long protocol, definitely it's a HCG trigger. But you have to keep in mind cycle history as well, wherein you would benefit from a dual trigger of decapeptyl plus HCG, wherein perhaps you have a lower maturity in the previous cycle, wherein you can benefit from a longer protocol or longer duration of trigger versus pickup, longer generation time. So you have to individualize the cases.
So in a nutshell, I would say that all sort of protocols are fitting for all sort of patients, but you have to select a particular patient, whichever protocol is suiting. So that means you have to individualize each patient and be patient specific. Take the patient's features, individualize the patient, take it per patient wise, put down the parameters and then select. Like if this is this particular patient is there for a low, because evidence says, it does not say that if the patient is a normo-responder or a hyper-responder, stimulate so that you can get maximum oocytes. What Pranay sir said, he said, we should have maximum number of euploid embryos in the end. Those euploid embryos we can get from 10 good oocytes also. Right. So likewise, for the same patient who is a hyper responder or a normo responder also, you may get from a lower dose possible also. Not necessary that we need to stimulate from a higher dose. One is patient safety, that is to be ensured. A normal stimulation is to be given, not a hyper stimulation is to be given even for a normal responder. Likewise, there are softer stimulation protocols for poor responders as well, and they may respond very well. Similarly, the transfer. So individualize each patient for a particular protocol. That is what the current norm that is going on, right? Now, the next is we move towards the endometrial receptivity a bit and the genetic component that is being associated, which eventually affects implantation. Role of genetic counseling. There are various genes responsible for embryo. So can you enumerate some of the genes that are responsible for affecting implantation? Just one or two, because and how does how can this patient be taken up further? Any role of genetic counseling, any role of embryologist in this?
So foremost, you have to be mindful of what patients you are looking at to offer genetic testing. It would not be all. It would definitely not be your index patient. Patients who are perhaps who at the outset meet the criteria, wherein advanced maternal age. I'm talking about genetic testing of both embryos and endometrium. When you're talking about endometrium, the ERA, which is a proprietary test, it looks at 238 to 280 genes, which consists of various mucins, cytokines, chemokines, and other mucopolysaccharides. So it leukemia inhibitory factor and C6, CXCR4, C6, CCR5, various name genes, 238 to 280 of them. So we perhaps would reserve endometrial testing, genetic testing for endometrium, that is the endometrial receptivity array, for patients who are having recurrent implantation failure. For genetic testing of embryos or looking at genetic testing of the the male and the females at the outset would be patients of advanced maternal age, patients who are having deranged semen parameters, severe oligozoospermia, severe oligoacinoteratozoospermia. So all patients with azoospermia who are going to embark on surgical sperm retrieval. So
they have translocations. They have translocations that need to be detected because they can pass on to the offsprings.
Right. So these are the patients who at the outset, before embarking a IVF cycle, would require genetic testing. Of course, we are not going to talk about genetic testing for monogenic disorders, wherein either the couple, either partner has a known genetic mutation or is a known carrier of a mutation, wherein these would require PGTM for reasons apart from infertility.
What particular role does an embryologist play in this testing that will eventually give you a good embryo with better implantation rates?
So foremost, I mean, if we talk about PGTA, we have a pre-PGTA counseling with the embryologist, wherein foremost we need to tell the patient that these are the indications that for which we are embarking on PGTA. What the whole process involves, we will break down the cycle over and above the normal IVF cycle, wherein you would have a stage of stimulation, pickup, and embryo culture, and genetic testing of the day 5 embryos and freezing. And then pending the results, you will then have a frozen embryo transfer. And then most importantly, we'll have to tell the patient that for the particular age that we are performing the PGTA testing, what is the likelihood of that patient reaching a day 5? Because we have to, actually the patients who end up requiring PGTA testing are the ones who have difficulty in forming blastocysts. So patients who are 39, 40, 41, 42, wherein they have higher chances of chromosomal abnormality. These are the very patients that would have difficulty in forming blastocysts. So then they have to be adequately counseled that there are high chances of cycle cancellations if they're looking at culturing all till day 5, because we feel that some of these patients who are making 2, 3, or perhaps less than 5 oocytes, we retrieve 4, have 3 mature, have a couple fertilized, they would perhaps benefit more by a day 3 transfer without genetic testing, because they don't reach till the stage of blastocyst. So they have to be they have to be adequately counseled regarding the chances of cycle cancellation.
So this counseling should be a part part of initial assessment and this thing whenever we are dealing with such patients. So these are select category of patients. Now, one thing that I wanted to ask is I just wanted to know about the procedure. Does the procedure of this blastomere biopsy, what is the correct time? Does zona affect zona breaking? Because eventually we are breaking it through a laser or something. So does it affect growth of the embryo or the quality of the embryo? Will it affect?
So there are studies coming from a lot of centers, and especially in Spain and Europe, wherein they have looked at the euploidy rates of the embryos from the same center, wherein different clinicians are stimulating their patients, and they have found differences in euploidy with regards to the person who's stimulating the patient, doing the pickup, or even the embryologist who's handling. So you'll have somebody who's having a lot of finesse will do the procedure in minimum time required with lesser number of laser shots, and will be well versed when to use one technique over the other, whether to use laser or just mechanical flicking. So that being said, yes, the lab, the clinician, the embryologist, the person who's doing, how he's doing, definitely affects the euploidy level and also the level of mosaicism. Second, the day of biopsy is now day 5 or day 6. We don't no longer do a blastomere biopsy on day 2 or day 3, because we now know for a fact that day 3 biopsies give rise to lesser implantation potential, presumably because we really don't know the blastoma that we are biopsying is either going to form ICM or trophectoderm. In case it is going to form the ICM, the implantation potential is severely reduced. With regards to effect of zona breaking by laser, it is comparatively safe. You have to do minimal shots with the minimum power settings. How the lab is, yes, we have discussed how the lab and the embryo handling. Pooja mentioned that pipetting stressors along with other stressors do impact not only the embryo development, embryo quality, but also perhaps the euploidy level as well. With regards to last point on vitrification versus slow freezing, I think is no longer carried out. We have comfortably moved to vitrification for all embryonic stages. For perhaps 2PN, the data is still equivocal, wherein slow freezing performs as good as vitrification for 2PMs. Definitely for ovarian tissue, which we are not going to be talking about, slow freezing has a larger data set as compared to vitrification, but now with vitrification as well, we are getting equivocal results as compared to slow freezing.
That was excellent. Rather, a very good description about how, because most of the times clinicians, even I would not have such an elaborate knowledge on these particular questions. Even I wanted to know about it. That is why I have put these very specific questions, which I think all clinicians should at least know. We should be aware of which patient to select, counsel, and yes, someone is there in the...
Yeah, Veronica ma'am, I have a question for Dr. Pranay. Sir, I have seen a few embryologists doing this one biopsy on a hatched blast, whereas some of them prefer to do in an expanded blast. Does that affect the implantation rate?
So some of the embryologists, they do a...
They prefer doing in a hatch. They wait for the blast to hatch. Yeah. No, day 6. They wait for the hatching. Yeah. So is it like...
So I think if you have an in-house embryologist who's having the technical expertise and you're not dependent on a visiting embryologist, it is a good idea to do a day 5 and a day 6 staged. I mean, the blasts that are ready on day 5, 4As, 5As, popping up, they should be biopsied on day 5. And then you culture the rest till day 6 and do the second set of biopsies on day 6. If you are having somebody flying just to do the biopsies on one day, yeah, you can do culture all till day 6, but then you'll have I cannot comment on that because I don't feel comfortable with that, but that is something that can be carried out because culturing a day 5 embryo, which is euploid on day 5, is not going to change its euploidy level. Perhaps, there is no difference between the technique with regards to either hatching previously, that is hatching on day 3, day 4, and then waiting for trophectoderm to herniate and then do a biopsy, or actually coming just on day 5, doing a biopsy, collapse shot on day 5 and making some space between the trophectodermal cells and the zona, and immediately creating a shot and just going in and grabbing the trophectodermal cells and biopsying. What you have to lose with the day 3 or day 4 zona opening is that on day 5, perhaps the cells that are herniating would be towards the end wherein the ICM is located. So you will perhaps have to abandon that opening and have to create a fresh opening. So what we do is we wait for everything to no day 3, day 4 shots, all trophectodermal opening, zone openings to be made on day 5 or day 6, and grab the trophectoderm and do a biopsy on day 5 and day 6.
I think there's a consensus on use of laser on day 5 or day 6. And day 3, laser zona thinning or creating a hole is no longer recommended because ICM might just pop out. Considering Pranay, even if you are a full-time embryologist and you have a laser and there is no flying embryologist coming, still still we are forced to do biopsies on day 5, or because we fear that the embryo might just hatch on when you're off the lab during the night time. So it's not always possible to you're working only during the day. It's not possible to come in the evening and come in the night, although we at times do the same, but it may not be possible always. But then I think doing, even if it's a non-hashed, even if it's a 3AA blast, it's fairly comfortable doing a biopsy on it.
Yes, good evening all. Myself is Raghunandan. Thank you for giving this opportunity. I'll just make one comment here. As Dr. Pranay said that maximum times we will reduce the pulse whenever we are doing the biopsies so that we can reduce the damages. So instead of giving a lot of laser shots, better to give a minimum pulse with a minimum laser shot so that it may not affect the trophectoderms or any other cells.
So on a consensus on which particular day, both the days are as good for performing day 5 as well as day 6?
The that are ready on day 5 should be biopsied on day 5. The ones that are early blast should be cultured till day 6, and they should be biopsied on day 6. Day 7, we don't recommend because there's a very high aneuploidy rate.
Yes, it has gone further into development, so we would try to avoid that.
There is a lot of literature supporting,
Yes.
day 6, if they're euploid, they implant as good as day 5 embryos. So
I have a question, Sarab, Pranay, anyone of you can take it. What time do you think is a better time to freeze the embryos, the blasts I'm talking about, when they are actually completely expanded or they are still the early blast? What is a better time, or anything is good?
This is non-biopsied blast, ma'am.
Yeah, I'm talking about non-biopsy blast.
So now with the newer protocols, with at least a couple of medias that I can recall, Kitazato, Krautech, and one Cooper Surgical DMSO, they don't recommend collapsing, but we have found in our hands that even with these medias that do not recommend collapsing of fully expanded blastocyst, these fare better with a collapse. And since past 3 years, we have been collapsing all our blasts. So in my opinion, previously we used to feel scared of vitrifying 6As and 5As because the cryo survival without blast was not 100%. Now with collapsing of these 5As, 6As, we have close to 100% cryo survival post-warming. So in my opinion, if they are early blasts, you have to see if you're on day 5, you come in the morning, you have 4 to 6 4As, and you have perhaps 2 or 3 early blasts. You can comfortably finish everything in one go because you will freeze. How we freeze is we'll freeze first 2 or 3 singly, The fourth one will freeze 2, and then the early blast will freeze 2. So I feel no benefit of culturing them because we have adequate. But if on day 5 you come in the morning and you have perhaps only 1 or 2 forays, and majority of the cohort is early blast, we will reassess them before leaving. So what we do is we do a reassessment at 3 p.m. If they're expanded, they are anywhere near 3 As or beyond, we'll take out the media and we want to finish by 5. If you have nothing, everything is early blast by day 5 evening, you'll have to culture till day 6. So
Okay.
yeah,
So basically, I gather that you want them to expand.
we want them to
because
expand to know the cellularity, and it's better to we cannot comment on 2As because it's at 2A stage you cannot say whether the ICM is A. So let them expand. Once they have expanded, we know their expansion potential. So then collapse. Collapse in the sense for vitrification post-warming cryo survival. Otherwise, the ease of vitrification is for collapsed blastocysts. So without collapsing, 4As will fare less better than early blasts and 3As.
So Pranay, I would like to, come in there because, we have stopped collapsing blasts since a long time now. We are using, shall I name, we are using cryotic media now for a very long time. And we have found no difference in collapsing, and we like to freeze early blast. Third grade of expansion, we like to as a priority, and then later on when we warm, we like to culture them for at least 2-3 hours and see how they look like. But yes, in third grade of expansion, you can grade ICM as well as you can grade the atrophyectoderm. So, and when you collapse a blast, the fluid goes out, and it is as good as a morula, in my opinion. I mean, then why not freeze a day for embryo?
Because then when you
Then
freeze on day 4,
culture it again for a day, and then you can grade the morula,
when you
the
freeze a
resulting.
day 4 fully compacted morula, you don't know whether it's going to form a 4A, 5A, 4BB, 4BC.
Absolutely. That is what you culture.
Once
There
you
are
freeze day
a lot of
5,
labs which are freezing day for embryos, and then they culture for another day, and then they grade the embryo and transfer it accordingly.
but you would have to thaw out, freeze and thaw more day 4 embryos than required. If I'm doing the same exercise on day 5, I just have to vitrify 1 4A and thaw 1 4A. If I'm doing it on day 4, even if it's a grade A, fully compacted grade A, or even early blast, I don't know whether it will form a
If you are
4A.
doing only single embryo transfers, then definitely day 5, day 6 freezing is in. If you are, okay with a double embryo transfer, then freezing 2 morulas and thawing them on day 4 and taking day 5 is not a bad idea, because in any case, a day 4 freezing works out much better even in untrained hands compared to a day
What's your
5 freezing.
standard practice, Pranay? Do you freeze one?
Yeah, so I'll
You freeze one embryo, one blast at a lock? That's your standard
answer that
practice?
one, I'll just answer a previous something related to the comment that Dr. Sarpreet made, that yes, you have to look at your data, what your implantation potentials are, what your cryo survival is, to comfortably embark on single embryo transfers. We're not talking about single embryo transfers here, but yes, then you have to also look at your learning curve. We were comfortably vitrifying and warming day 3 and day 4 when we started, and we were struggling with day 5s because this was 2015 when we started, and we were working with non-DMSO medias. We did not know that DMSOs would perform better. So once you have acquired the finish, then yes, then I will answer your question, what my standard practice is, which has come after a hit and trial of so many years. Our standard practice is culture till day 5. We don't do any day 3 vitrifications rarely. If we are doing a day 3 vitrification for a poor responder for whatever reason, whether hormonal parameters are aberrant, thin endometrium or whatever, it's a day 3 warming and same day transfer. We don't do day 3 warming and day 4 culture or day 5 culture or transfer. If we are culturing all till day 5, we will do a day 5 vitrification after collapse of the blastocyst. Freeze. If let's say we have 5 blastocysts, we'll freeze the first 3 singly, and the last we'll freeze in twos. We want a flexibility of doing a single embryo transfer without having to re-vitrify on the day of embryo transfer, because sometimes, patients change their mind. Initially, they want a DET, especially with the patients who fly in internationally, but then they read and they want a single embryo transfer. So we want to be ready in the event that on the day of warming, we have to do a SET, we are not having to revitrify the other one, even though studies have come in that show that revitrification does not reduce the implantation potential too much, but we don't want to indulge in that exercise anymore. So let's say for a hypothetical example of 5 blastocysts on day 5, first 3 singly and the last 2 will freeze on the same device. That's how we do it. For some patient subgroups, we do mandatory SETs. I think that's not the question, but let me still touch upon it. SETs are for young patients less than 35, patients with previous cesarean, advanced patient age 45 and beyond, uterine abnormalities, and previous history of cervical incompetence. So these are surrogate transfers and OD transfers. So these are 5, 6, or 6, 7 absolute indications for us to be doing SETs. So now we have moved towards freezing singly, even though it's a time-consuming position.
So I have a question. Once we thaw the embryos, sometimes after 3 to 4 hours, we see that the blast has expanded partially. So should we wait for the complete expansion, or we can just transfer it out?
So now what we do is we calculate our degree of expansion post-thawing. Some of the softwares, especially the ones that come with the laser, they come with image mapping tools. You simply have to do a 2 diameter study and calculation, and you see post-warming, 60 minutes post-warming, if the degree of expansion is even just 20% expanded. These are the embryos that will that have highest implantation potential. So in our practice, we have seen that any forays that we have vitrified and warmed, they come out totally collapsed, and by the end of 2.5 hours of culture, they are 5 ways and popping. We also, I would want to add that we do laser-assisted hatching for all of our vitrified warmed blastocysts, even though the evidence is equivocal.
Is there any time cutoff we should wait for the expansion of the embryos? Like we should wait for the expansion?
So if you are having absolutely no expansion in 1.5 hours, I would go on to warm another straw.
Okay.
And is there anyone trying that if one has freezed day 3 embryo and patient want blast transfer, so after at the time of FET growing that embryo to blast stage, is it any comment about this?
Yes, so you need to look at your numbers in the sense that what is your lab's cutoff for grade A embryos on day 3 to confidently predict whether fresh or frozen. Once you've thawed of day 3 embryos and they come out to be crisp grade A's, there's no difference between the culture journey for fresh versus frozen. So 3 grade A's on in the fresh cycle will behave as the same as 3 grade A's post warming if cryosurvival is absolutely fine. Okay. So for us, we need at least 2 grade A day 3 embryos to confidently say that we will have 1 blast. Okay. And 3 grade A embryos on day 3 to confidently say that we'll have at least 1 4A blast. So then again, you have to look at your numbers as a lab. We started with this number for us when we started was 5. We had to thaw 2 straws initially to confidently say that and previously we were doing double embryo transfer. So with 5 warmed, we were confident that we will get 2 blastocysts. Now with 2 or 3 day 3 embryos, we are confident that we'll have 1 blast. So you can, but you need to be prepared. Your embryologists need to be prepared with a dish which is oil overlaid for the eventuality that you are not going to transfer this, you are going to culture this. Because some days you will have just a FET, you may not have equilibrated oil. So be prepared for that eventuality that we are not having a fresh transfer on that day, but we are having to culture.
And one more
That
thing
implies
is
that the synchrony between the clinician and the embryologist should be there. If you're planning an FET transfer and if you're planning, you have frozen a day 3 and you're planning to take it to day 5. So the lab also has to be prepared at the same time.
Right.
The lab, and one more thing here is what is the grade of embryos you have frozen on day 3? It depends upon that also. So you have frozen a 6 cell or like 7 cell with a C grade, and you're expecting okay, embryologist is not giving good embryos on the day 5. No, it doesn't work actually. So you have to be very keen. Note that on the day of 3, what grade you are freezing. So that also matters. As Pranay said, so at least if you're keeping 3 out of the 2 has to be very good one. At least we can expect some blast on the day 5.
True.
True.
Yeah, plus
Okay, I
it
think
depends
we'll
on
move the panel forward
Yeah.
because we are short of time. Sir also has to go somewhere. Sarab sir, your
Yeah.
question next.
So can you hear me?
Yes, sir. Yes, sir.
I think it's your question, but anyway, I'll just take it. What should be the lab conditions? I'll just enumerate, and we'll go on to the next question.
Yes.
So the culture environment, you're targeting a temperature of 37 degree with a difference of plus minus 0.1 degrees. This is the microenvironment I'm talking about, oxygen level of 5%. I think Pooja has gone through
Yes,
these.
Pooja has enumerated in detail also. She has spoken about it all the most of
Microenvironment also, I think, is equally important. So the message is that the quality parameters can never be maintained in an ill-conceived or a ill-planned IVF lab. So you need to have a proper planning. Even if you go through the Cairo consensus, they have clearly mentioned in old generation labs, the VOC levels were significantly higher compared to the new generation labs, in which, we tried to segregate things in a much better way, plan things in a much better way, and we are using low VOC materials now, and the VOC levels are much, much lesser. So the idea is, well begun is half done. If you plan a proper lab, half the job is done, and you can think of having good implantation rates. And so the question for Pooja, are you there? Dr. Pooja
Yes, sir. Yes,
Awasthi.
sir. Yes, sir. I'm here.
Pooja, so do you think that embryologists should be consulted while planning an IVF lab?
Definitely, sir. Definitely. Because
So what difference can make?
yes, sir. Yes, sir. So making an embryo, making a lab is actually integral part of both the things, like the clinical OT and everything, and also the lab. So lab parameters are very, very vital, and they without a good lab, we cannot simply make good embryos. So I think a embryologist consultation must be there while you're planning or making your labs, or even if you are doing it some refurbishing work or something like that.
So at what stage should an embryologist be hired? Planning, procurement, installation, or commissioning, or like after commissioning? I mean, what should be the right stage of hiring an embryologist?
So, sir, because I work as a consultant embryologist, while we are setting up, having the idea of setting up an IVF center in a particular area. So, I think this is the beginning. This is a time when we should be collaborate with an senior embryologist who have the knowledge. So, from the inception of idea, where is we are going to create the lab, which floor, which area, and how many, I as per the ART rules, how many rooms, what is the area sizes, and how about AHU, what all equipments, how to maintain the quality of the air. So all these things. So I think from the beginning of the idea of having a lab.
Okay, so we move on to the next question. We agree with Pooja that the embryologist should be hired right from the conception phase. The question here is, it goes to Raghunandan. An IVF clinician hires an experienced embryologist after the construction is over. Procurement of equipment is done as per the company's advice with whom they are dealing, and the installation is due to start next week. So what will be your advice, Raghunandan, to the IVF physician? What will you advise? Now the installation is complete and they want to start off. So what will you tell them?
Sir, on this question, I'll make a comment on, like, better to, as Dr. Pooja said, that better to hire a person before. If the person is not hired, at least they should meet, like, make some communication, or if they know the thing, like if somebody has to be hired for the position, or like if they want to extend the time also, at least they have to make a contact with that person so that they can get some
With you, but
information.
now the situation is different. Now they have set up everything, and they were talking to somebody, and now they are, not talking to the guy, and they have hired you now. So what will be your advice now?
So better like the person who is like hired, he has to be at least have some 4 to 5 years experience more than that, so that he know how to troubleshoot everything. So that if something like he has to know where to plan, like when, like what are the equipments and where to keep it. Even that person will be having so much of experience that even though if a different incubators, for example, benchtop or like box incubator or case system, whatever it is. So he should be exposed to everything so that he can handle everything for that whatever he got the equipments. So at
Now the
least that
installation is
experience
done.
matters.
Now the installation is done, and they want to start the cases from a week's time. So, any particular advice you would like to give them?
Obviously, yes, because he has to do the vigorous cleaning. So because he has to go for the air quality testing before that, and he has to do the cleaning of the equipments and calibration. So he has to go through for all these things. So within a week means like he has to go for at least a vigorous cleaning to rule out all this micro contamination.
So, Pooja, do you think they can start within 1 week of installation?
So what I feel is that 7 days is lesser time, I guess, because
So what
at
would you
least
advise to
15
them?
days is the adequate time before we are planning to have an OPU. So 15
क्या
days is
क्या
enough
करेंगे
time.
15 दिन में क्या करेंगे आप? I mean, what is your plan?
So this, if it is a new lab, then we call it burning in. So burning in of equipment is also very, very important. So we have to run the equipment after calibration, and if any kind of manufacturing defect or any misalignment happen, we should be knowing in advance that what we need to be done. Any surprises while we are doing pickup is something nobody likes. So I think, and obviously, as Raghunandan said, deep cleaning is important. Cleaning over cleaning is very, very important.
So
So
what do you understand by burning in? Can you explain burning in for the benefit of the?
burning in means we have to run the equipment for like continuously for some 3, 4, 5 days and observe is there any kind of manufacturing defect. And also all the incubators, if we talk about box incubator, they take 2, 3 days to come into the functioning because they have got disinfection cycle, then they auto start. And then we have to also perform sperm survival tests. It also takes around 24 hours to 48 hours to get what is the functioning of your incubators where you're going to culture your embryos. So I think 10 days, I feel, is the 10, 15 days.
You did mention about air quality. What parameters are you looking at when you say air quality?
Air quality, we generally do all the checkup for the VOCs, presence of VOC, particulate matter. And I think the company people who have established the lab, they have a certain protocol, like 1 to 10 numbers, parameters they check and count, and then let us know that your lab is good to go. So, yes.
Okay. So on reviewing the contract with the company, you find that the company has assured 1 year of free service to the client, which includes checking partial pressures in incubators and temperature every 3 months, checking VOCs every 6 months, and checking particle count almost once in a year. So do you think these norms are good enough? Pranay, would you like to come in?
So actually, we do all of this ourselves, and a lot of them every day. But for somebody who's just set it up, we need so assured 1 year of service. I would always insist, um, uh, haggle with the company people for more warranty because we want at least 2 + 3. So that's how we haggle. And apart from this, we haven't talked about the optics. So we would also want the optics to be covered in this 1 year of service. So we're looking at with regards to the incubators, box and benchtop, temperature and flow for the benchtop, and temperature and the CO2 and O2 for the box. With regards to the IVF workstation, we'd want the flow, the light intensity of the stereo zoom, the vibration of the workflow, and the temperature of the integrated heating surface. And all the you need to have the people who are dealing with lux, who are carrying lux meter and the likes to have the same post-commissioning checks that have been done at the time of installation to be repeated at least annually. So that would include the flow from the inlet of the positive pressure module, and confirm that the adequate number of air changes are taking place. So that would be my checklist. This is over and above what is there in the OT and the embryology in the ultrasound lab. So when you're setting up a lab, insist for a warranty which is extended, and once your warranties are expired, you need to have at least AMCs for the box, the benchtop, the microscopes, inverted, and the ultrasounds. These are minimum. And a very good idea to start a lab which perhaps might not fit everybody's budget is to have tools of everything. At least have tools of your oocyte aspiration pumps. Sorry.
You should, that is what I wanted to point out, that instead of spending on things which you can save on, it's better to spend on quality control instruments which have to be in-house. And we have to check temperature every day, we have to check CO2, oxygen. Most of the things are to be checked every day. Even the optics have to be cleaned and reviewed. So insist on buying instruments which you can definitely manage in-house, and for the rest of them you can have at least a 3-monthly contract for checking pH, or an annual contract for checking the particles, especially after the change of filters. So these kind of things have to be incorporated in the AMC contracts. So for air quality, you need to have a particle counter and a VOC meter, which you can definitely outsource. I don't see much reason in buying them. But you should definitely have a temperature probe, as well as a CO2 analyzer and an oxygen analyzer. And for pH, you can outsource it to the company, or if you're working in a big hospital like we do bring in the blood gas analyzer from the ICU nearby, and we try to check it in-house every couple of months or every 3 months. Or else, Pranay, how often do you do the pH checks?
We depend on an external annual check, because even though it's not recommended to have CO2 as a surrogate for the pH, but that suffices for us in an annual check.
Yeah.
So otherwise, if you can afford this particular instrument that is shown on the right, the Epoch, it is an excellent tool, apart from some of the newer incubators who have inbuilt online pH testing. So if you have the money and the resources, nothing like it, especially with because the purists will insist on getting pH check with each lot of media. Every lot of media coming in, you have to check the pH after equilibration. But that's something that we cannot afford at.
Not visible actually, to get it checked that often. But yes, I know of labs which do pH every day. I mean,
so we do CO2 every day, and that is good enough for us. I mean, there's no reason for us to be. I mean, we have found that once you have your box incubator, the benchtops are connected to the tri-gas, your CO2 and O2, they remain relatively constant, but it's just a matter of habit that we end up doing it every day. And similarly for the box, we do it every day, because we find that at least the TC sensor based box incubators have a very high drift. Our IR sensor based box incubator has it's very stable. It will not have drifts over years, but the box incubators having TC sensor, they will drift over 3 or 4 months. So that's how often we need to recalibrate.
So any other air quality checks besides particle count and VOCs do you carry on?
So yeah, we have been forced, sorry, not forced, but now the newer guidelines, they mandate the periodical air sampling and swab testing from various surfaces. So that's what we do. So we do it from the incubators, the laminars, the settle plate in the lab, in the OT, in the workstation. So that's what we do.
And besides, I would just like to sum it up by saying that continuous positive pressure monitoring is also very important. So you need to have pressure gauges inside the lab which can help you judge it. Otherwise, the crude tests, or you can use paper strips and other pressure indicators. And you got to maintain your HVACs and AHUs with constant surveillance and filter changes, coil cleaning and driver belt replacement. This is a little technical, but yes, all the clinicians need to know this. And the HEPA filters have to be changed periodically. Like we are sitting in Gurgaon, a lot of construction is going on, so we might have to do it every 6 months. But somebody who is sitting in, like Dr. Futela is sitting in Rudrapur, which is a very green area, she might be doing it every 1.5 years. So things change as per the surroundings also. That has to be kept in mind. And going on to the next question, sorry, I'm rushing a little because we are already very late. So an IVF clinics protocol, all ICSI cases. After ICSI, the embryos are cultured in benchtop incubators, and then they are finally evaluated on day 5. There is no check in between, no time lapse monitoring. All blastocyst transfers days 5 and day 6. Blastocyst formation rate is 43%. Usually they'll go for a single or double embryo, double blastocyst transfer. The IR rate is 25%. So what do you think, Pooja? What can be the reason for a lower implantation rate in such a lab? If you want, you can read the question once again.
So I feel there could be number one could be the gamete quality itself. Number two, you mentioned that no check on I think day one, no PN checks and nothing. You are taking it on directly from day 5.
They
You
are
don't
putting in
know
one sperm.
about the multinucleation.
Yeah, it's all they're putting in just one sperm confidently, and then they're checking it on day 5.
Right, sir. But what about 3PN or 2PN? It's not about just putting one sperm and
So the likelihood of 3PN
air
in
quality and I think the basic after that, if the gamete and handling is all okay, then I think the overall quality of air could be the culprit in this scenario.
the VOCs might be higher.
So, if I may,
Yeah, Pranay, please.
I mean, as embryologists, we have this tendency of taking everything upon ourselves, but don't take everything upon yourself. So if you're keeping in line with your performance indicators, if your KPIs are not reaching perhaps benchmark, but your competence is fine, it's beyond 40% for blastulation, and these are good quality blastocysts, ask your clinician to troubleshoot as well, because you have to look at the time period for which you have dug up this data. If it is just 1 or 2 months, perhaps don't be perturbed that much. But if it is 6 monthly or annual data, then yes, you have to do this troubleshooting both at the embryology and the clinical end. I'm presuming all these temperature, osmolality, pH, VOC, particulate count parameters have been taken care of. And now you have to shift the onus onto the clinician with regards to the endometrial preparation, the luteal support, the kind of embryo transfer that they're doing, the technique of embryo transfer.
True.
And yeah, so don't take everything upon yourself, especially if you're making good quality blasts.
Yeah, so that's what we were coming to, the clinician's expertise in the end, so which you pointed right in the beginning. So I'm pretty happy about it, Pranay. So Dr. Anuradha, over to you, Dr. Veronica, over to you.
So when it comes to being the embryo as one of the most important aspect, which affects implantation and of course the procedure, that is embryo transfer. So now we all know from the previous discussions that it's the most crucial step. And what are the factors that need to be taken care of while planning the procedure, and also factors that will help us help us have good implantation rates.
Dr. Veronica, I think Dr. Anupama has nicely addressed these.
She has elaborated in detail. Yes, she gave a
Definitely,
very
they
good
have been
answer.
discussed. I think
If
anybody wants to add anything, otherwise we can
Yes.
go to the next question. Yeah.
So next slide. I think these all thing. One thing that I wanted to ask, the technique of transfer, does it affect from the time? And one question, from the time of loading the embryo in the catheter to the time it is placed, does that matter?
So I feel there is a lot of literature which says that the whole process of ET has to be complete within a period of 2 minutes, whether you're doing a preload or you're doing an afterload. And there are different indications for generally we prefer preload techniques or afterload technique, but yes, some labs do go for preload also, especially when the clinician is proficient in the handling of catheters, they like to go for a preload. But mostly, in my experience, I have done almost 99% afterload technique. In a few centers, I've done the preload technique, and I don't think there is a huge difference between the two. But if you are very confident about that you can
They give you
negotiate,
actually equal comparable pregnancy rates,
yeah, and
right?
but different indications, if you are confident that you can safely negotiate, and you can place the embryos at the right place, you can go for a preload. But if you think that you're going to, take some time to maneuver the cervical canal and reach the outer has to be at the internal os, and if you think that it's going to be a difficult transfer, there is some stenosis, then an afterload technique is definitely suits you much more.
So when we move further in this discussion, most of the questions Dr. Anupama has already answered in her talks, that is factors affecting the endometrial receptivity, which is one of the very important factors. Just one thing that we should cover up is the uterine factors, the various factors that need to be assessed and well studied. Dr. Pratibha, if you are there, and the adjuvants that can be used in improving the outcomes. Adjuvants, are they helpful?
In case of adjuvants, madam, if the patient is a case of thin ET, then reassessing to reach the optimum endometrial thickness, the mode of administration of estrogen and is helpful. Otherwise, there is no established role of aspirin, low molecular weight heparin, or PRP, arginine, in the improvement of the endometrial thickness or receptivity. And sildenafil, though, was recommended by Canadian guidelines as they are helpful in cases of thin endometrium. So otherwise,
what is your take on the endometrial receptivity ERA test? ERA test.
ERA test is still not established as the one, but there are studies which are coming up. It's in the even some of the RCTs have come up in 2022, which says that the better implantation, and actually no difference was seen in the implantation failure cases and the regular first IVF cycle patients. But reassessment of that in 2023, again, the significant increase in the implantation or clinical pregnancy rates were not seen. So it still has to find a way in clinical practice, and it's expensive. But apart from that, individualized cases where the treatment has been very rigorous and many IVF failure cases, we do advise for ERA.
Should uterine cavity, should it be evaluated in depth?
Uterine cavity evaluation, basically TVS 3D. 3D is a very good tool to assess the endometrial cavity. And if there are certain issues that we are not able to, if the patient has some of the transfer failures, then I think like in cases of chronic endometritis or sometimes Asherman's, which are partial, which cannot be diagnosed sometimes in 3D, hysteroscopy might be needed. It is one of the established treatment advice for RIF cases. It's catching, it has not found its role as of now. And
all these things have not
myomas,
been
polyps,
very
septum,
beneficial.
if they are having any symptomatic problems are there with the patient, then treatment is of course advised. And if they have otherwise, just for the primary infertility cases, they are the guideline is not very supportive in going ahead with these treatment for these cases.
Raghunandan, what is your take on various culture media? One step or sequential?
So I've used both the things, ma'am. I'll go with a sequential because even though like if the person is doing a freelancing thing, maybe they'll use the one step. Anyway, we are having a in-house, so I'll go with a sequential media.
Your reasons? Any reasons?
So as I observed, even though in the one step also we will get the sufficient whatever the benchmark blast, but in sequential we used to get a very good blast release. This is my experience. So what I observed.
Some people also change the one-step media at day 3.
Yes, we can do that. So
What is the advantage or benefit of doing that? Can't we continuously culture it? Nowadays, we have time lapse. So
see,
we
if you
can
are
monitor the growth of the embryo. We don't need to open the incubators.
yes, if you are doing a single embryo culture or single gamete one, that is well and good. But if you are doing a group culture, so then it requires a minimum amount of the sufficient nutrition. So we have changed on the day 3.
So to just to sum up, because everybody, we are actually a little late in winding up.
Yeah, we need to wind up early.
So there is not much of a difference between single step and sequential in terms of results. So many studies have come to the same conclusion, and so the dilemma
Sarab,
is.
Would you allow some questions, Sarab? I know it's very late, but we don't catch you
Dr.
intelligent
Anupama,
guys
I
very
will have
often.
to ask you many questions. But yes, we can definitely carry on. I think we're all part of the same WhatsApp group, so we can discuss in the WhatsApp group.
Just one question here.
Yeah, please.
At what temperature would you suggest thawing should happen? 37 degrees or room temperature, or it should be 25? What ideally is your experience?
It depends on the medias. So when we when we're using the medical media, the SAGE media, all the 3 steps were at 37 degrees. So even the first step and the second and the third step, so it had a 1% sucrose and 0.5 and then 0.25. So the descending gradient of sucrose, it was all at room temp 37 degrees. So you have to follow the media guidelines. So if you're using Ketazato or Kyotech or any other media, so mostly the first step is at 37 degrees, because the warming rates are more important compared to the cooling rates. So the medias are designed that most of the freezing is being done at room temperature. You go from 25 degrees to -196. But yes, only the Vitrolife media is working at 37 degrees, and it's actually working much faster because the permeability of gradients increases and equilibration is much faster. And we did learn on Vitrolife media, or we had actually in AIMS we designed a media which was similar to Vitrolife. So our first step was 4 to 5 minutes, and then 40 seconds, and the freezing was done. But when we shifted to Ketazato or any other latest generation media, the equilibration time is much more, as well as the vitrification time is also 60 to 90 seconds in most of the medias. But yes, thawing medias are usually universal medias. So even if you're using Ketazato, you have to follow the Ketazato guidelines, irrespective of the freezing media.
And do you put on the laminar flow at that time or not?
So you can put on the laminar flow. I don't see any harm because you're using big volumes and you're using dishes which have got caps. So I don't see any harm during freezing. If you're freezing in drops, especially the vitrification step, at that point of time you need to switch off the laminar flow the laminar airflow.
Okay.
I mean the air.
And the temperature of the lab at the time of ET and pickups, what should be the temperature at that time in the labs? 24 degrees, 25 degrees, that is what we usually maintain?
Yeah.
Or do you think of something else?
No, we don't change the temperature for during PU or transfer. We maintain it at 25 degrees only.
Thank you.
So I think we'll wind up. There was just one more question remaining, but due to paucity of time and a little delay in the events happening, so we'd like to wind up. Any questions are welcome in the WhatsApp group, which we are a part of. So with this, we conclude. There was just one odd question left after this. So we will not take up that question due to reasons well explained. I'll stop sharing the screen and we'll take a group picture and I request you to switch on your cameras, please, if you can. And we'll take a group picture just for the record purposes. Thank you so much. I would like to end. I'm sorry for ending it abruptly, but we are supposed to do it.
Absolutely, it's very late now.
It's such a pleasure to be a part of this
It's
discussion.
very good discussion, right?
Yeah.
especially
Thank you.
embryology part.
We will again do, and after 2-3 months, again we will call sir and we'll ask him to give a talk and discuss all the remaining part.
Actually, clinicians को सबसे ज़्यादा embryologist की opinions
Embryologist की, हाँ.
we love it. Raghu, you were very good.
सही बोल.
Pranay, you are always the best. Sarab का तो कहना ही क्या है. Thank you so much, everyone.
So we all
Thanks a lot,
request to
sir.
participate in next events so that the remaining doubts and clarification we can get you directly from you.
Perfectly fine, ma'am. We can plan a question answer session next time and on
Yeah.
the same topic.
Which will be very long, huh? Be prepared.
We will keep we'll keep only discussion, panel discussion only.
Yes, yes, we can
Small
keep
talk
only
and all
panel
that will be-
discussion where everybody can ask questions
ask
and
questions and
So thank you so much to Dr. Veronica, Dr. Anuradha, Dr. Anupama, Dr. Pranay, Dr. Pooja, and everybody else. And thank you so much. With this, we call it a day. Thank you.
Thank you
My
everyone.
pleasure,
Thank you
sir.
so
Thank
much.
you.
Thank you.
Bye, bye.
Thank
It was a
you.
nice time with you all.
Thank you all.
Thank you, everyone. Thank you, Anupama madam. You too.
Thank you, ma'am. Thank you so much.
Thank you.
Thank you, Pooja.
Thank you, Dr. Anuradha, and thank you, Dr. Anupama.
अनुपमा मैडम फिर बात करते हैं, फिर मिलते हैं. अभी आधा अधूरा रह गया है.
Yes,
you
yes.
all.
Very interesting.
Yeah,
Actually,
Anupama
panel
madam
is
and Pooja,
always
nice to-
little lengthier so that we can
Maybe.
discuss.
Yeah.
There's so many things we need to discuss.
Actually,
but-
पूजा तुम्हारा बहुत अच्छा था. मैं ये सोच रही थी कि एम्ब्रियोलॉजी से रिलेटेड ना इतने क्वेश्चंस होते हैं और तुम ही लोग उन सब चीजों को बता पाओगे हमें ना कि ये अभी टेम्परेचर, पीएच,
Yes, yes, ma'am.
सारी
I
चीजें
know.
हैं.
So you're most welcome in the group. We all are there, na? And
In panel,
you can put any
I will
query.
add ma'am. I will add
मैं
ma'am
शायद नहीं
so
हूँ,
we
मेरे
can
ख्याल
have
से
the
तो नहीं हूँ
discussion.
मैं.
Yes, yes, definitely, definitely.
Yes, yes.
Okay, thank you so much.
Thank you
Have a
all the
dinner.
panelists.
Bye, take care. Good night.
Thank you. Good night.
Bye-bye.
Bye. Thank you, Sudha. You have done a wonderful job.
Thank you, ma'am.
Thank you. Thank you. Thank you so much.
Thank you, ma'am.